Dr. Kabongo, thank you so much for taking the time to sit down with me and tell me more about your work as a doctor in Canada. I'm excited to hear more about you, and I'm sure the audience who's watching us as well is eager to learn more. So you've been practicing medicine in Canada for 14 years.
Mm-hmm.
Tell us how it is that you came to have a career doing medicine here in this country.
Oh, thank you, Nadia, for all of these questions you're asking me. Yeah, I'm so happy to have you here. And thanks you for our audience that actually following us at this time. Yeah, coming and working in Canada and being registered as a family physician, it's been quite a journey. Yeah, so I was not trained here. I'm actually what they call international medical graduate. So my path to coming to Canada stems back from the Congo. This is where the Democratic Republic of the Congo. This is where I went to medical school, my basic medical school. After that, I went to South Africa. This is where I did my residency in family medicine. And then from there, I had my resume online. And then one day, I just received an email that Dr. Kabongo would like to work with somebody whose resume looks like yours. Is it possible we can have a conversation? I was like, okay. So I gave them a date, and then they contacted me. So I'm talking about like 15 years ago. And on the D-Day, we had a conversation. It took me like 30 minutes. So the little I know it was like, that was pretty much an interview. So then they were like, okay, I would like to work with you. And then we invite you and your wife can come to Canada and then to come and visit where we're working. So, yeah, that was 2010, but I had to come alone. Yeah, because we didn't have where to leave the children. So, yeah, I came and then visited all the infrastructures they were having. Yeah, I liked the environment. And then, so they gave me the contract and I signed.
So what's it been like practicing medicine here in Canada, the highs and the lows?
Oh, yes. Before even starting to that, so it's, it's not easy moving countries. Yes. Even though South Africa's system or South African system or medical system is pretty much similar to Canadian. That's why, especially at that time, South African doctors, especially family physicians could come from there and work here. Yeah. Provided that you need to write the exams. Because the system here is that you need to finish the exam, you finish the, you finish the exam from your university, and then you have to take the national exam. Once you pass the national exam, then you are registered. Yes. So that's why when we come up here, we have to take all of those exams with even Canadians. Yeah. So it was not that easy as well, I have to say. We have to adjust. So we're talking about like 4 or 5 exams. And they gave me like 5 years where you have to finish all of these exams. So it was not an easy thing as well, because I know when we came, were many of us, some could not make it. So if you don't finish your exam during that 5-time period, you go back to where you're coming from. Yeah. They will not chase you away. If you want to stay here, of course, but you're not going to be registered. Yeah. So what avail stay here if you can't work as a doctor? So many went back to South Africa. Yeah.
But you didn't.
Thanks God. Yeah. You didn't. If you still seeing me here, so it means things went well.
Things worked out. Are you happy it worked out?
Oh, yeah. Very much. Yeah.
What do you like about working with patients here in Canada?
Well, the country itself, Canada sells so well out. Yes. I usually tell people, especially some friends, when I came up here, they're like, well, what is it good there? I mean, but you know what? If you come from South Africa, you're not going to be very impressed. Okay? But what will impress you is how people interact with you. In that you cannot see it, you need to live it. Canadians are so hospitalist. I remember, you need an example. When I landed at the Vancouver airport, after traveling 2 days, because from South Africa to here, this is almost 2 days.
Long journey.
I was tired. Though the hotel was booked already, everything was booked. I landed at the Vancouver airport. I was so tired. And then I went there and I saw a guy person was like, do we have the hotel come and look for the clients here? We're like, some hotels they do it, some they don't.
Right.
And then the guy asked me, so which hotel are you going to? I gave him the name. He was like, oh, that hotel, you know what? If you go, it's just at the terminal, at the last station of the SkyTrain. So when you just leave the SkyTrain is it is our subway here. Even though they call it SkyTrain because up, it's not underground, but it's up. So if you take the SkyTrain here at the last station, once you get out of the station, the hotel is just there. And I was like, thank you. As I was leaving, the guy came and said, sorry, hang on. Probably, I know you might not be having some small change. Take this, he gave me like $3 or $4.
Wow.
Said, take it for the SkyTrain.
Huh?
I was like, actually it helped me because I didn't know where I had to go and find the small change. So I used that money and then I just jumped it, what he told me. As soon as I reached there, came out of the station, that was the hotel. Yeah. So they are very hospitalist. So it's really a very good environment to work in.
And what about the medical system? I'm curious, how does it differ from what you were used to coming from South Africa to here?
Well, yeah, so some differences in the sense that patients here, they tend to be more demanding. Yes. When they come to see you, you need to know your story. Oh, definitely. I tell patients, I tell friends, you come up here, you need to know your story. Especially now with the social media. Everybody has a cell phone. With AI, before coming, patients sit and read. Yes. So you need to be able to tell them different story. Yes. And that can be challenging. Yeah. So, but you know what? Medicine is medicine. And so another difference is you need to know how to communicate with Canadians. Yeah. In fact, for that, I have a small story. When I came, it's stressing. There's one exam that, I think the second exam, tried many times, couldn't pass it. I was like, this is the first time in my life I can write an exam so many times I don't pass it. And I wanted to know why. And I went to talk to the body that was organizing that, and then they told me, come and see. So no, because most of the exams, some are oral.
Oh,
yeah,
okay.
Yeah, oral exams. And there's a question there where a young lady came up with her armstairs. She lost her armstairs, and then the armstairs was that family members. Yes. So the main problem, she came with headaches. Yeah, that was the question. So during the exam, you have to find out what is causing the headaches. And as we were talking, she even volunteered to tell me that she lost her armstairs. I didn't pick it. And I could not pass the exam because I didn't know how to communicate with Canadians. They showed me that, look, you don't have empathy. You have to empathize with this woman. She lost her armstead. You should have asked this. How long have you been having this as a pet? Where did you get it from? And when did it die? So you need to empathize. That was the exam.
Interesting.
And I couldn't pass it. So until I went and learned how to communicate, passed the exam.
Interesting.
Oh, yeah. Yeah.
And so having to navigate that process, the exams, learning a whole new culture and a whole new way of approaching patients and medicine.
Yeah.
Was it worth it? Are you so happy you went through that whole journey to be here?
Oh yeah, definitely. I'm happy to work up here. As you can see, because when you come, they give you 5 years. In those 5 years, you basically work under what they say. You work under supervision. Yeah. Even though when I landed up here, I was working up north in a small community of like 5,000 people, and I was the only doctor there. Yes.
The only doctor?
Yes. Because when I came, the second doctor with whom I was going to work with got sick, so I ended up being by myself. So imagine you have 5,000 people. So that was the main population. And then for the catchment of that area, the people coming from small communities around, so it could bring probably maybe around like 6,000-7,000 people.
Wow.
And I was the only doctor working there.
Wow.
Yes.
Wow.
Yeah. But people were so accommodating.
Yeah.
So happy. Imagine like if because up north it was, snowing a lot. Like after the snow, somebody would just come and clean your driveway.
Yes.
When you come this, you don't even know who did it. Yeah. So it was so good working and living in a small community as well. Even though at a certain time you feel like everybody knows you.
Yes. Yep.
Yes. You can't carry yourself. Wherever you go, people knows you. Yeah. Okay.
How did you end up coming down here to Surrey?
One of the things that pushed me to come down was because up north we don't have many schools.
Yeah.
So we had children growing, and so that was the thing that made us not renewing the contract, because we came up with 3-year contract. Once it's finished, and then we came down in the big city.
Gotcha.
Yeah, especially for school for children. Yeah.
So now you've been here and you have this practice. Tell me the whole story around the journey to this practice. And was this something that you had always envisioned?
Yes. Didn't just come to here. I actually worked like 5 years as a hospitalist. So hospitals are basically family doctors work in the hospital. Yeah. For example, when you are sick, you go to the hospital, your family doctor might not be having some privileges to come to the hospital.
Yes.
And then you need somebody to take care of you entirely. Yeah. Because we work with specialists. A specialist will come, for example, if he's the bone specialist, you shake your bone, off he goes. And yet you might be diabetic. Yeah.
So we'll follow up.
You need to look at your sugar, whatever it is. So you need somebody that will be doing the care of your family doctor, but in the hospital. Yes, that is a hospitalist.
Interesting.
Yeah. So after that, and then once I finished my exams, I got fully licensed. So yeah, on the 6th year, I left the hospital, and then we acquired the place. So this is how now basically when you get your full license, you can establish yourself anywhere.
Wow.
Thank you.
What did you see when you were in the hospital?
Sure. Well, it was interesting. Yeah, working in the hospitals it has its own challenges, and it's good because you have a big team.
Yes. Yeah.
Okay. You have a big team of doctors around. Specialists, you can grab them from the coffee table. You talk to the neurologist. You talk to all of those specialists. You carry them there to your fingertips.
Yep.
Which we don't have in family practice. Yeah. Sometimes it takes a long time. You send the patients, it takes months.
Yeah.
For them to be seen. But in the hospital, they are there. You pick him, you will go and see your patient.
Yeah.
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 So that is good. And then you exchange information. It's so common and interesting.
Yeah.
Yeah. But the downturn, is just, you need to work sometimes at night.
Yes.
I'm not doing good at that. Yeah.
So aside from working at night, I wonder about your thoughts on the way that patient care is approached. I think you have another way of describing it or characterizing it. In your opinion, was it working?
Well, anything that a human body has done, there's always something that will miss somewhere. Yeah. So the system works, but the problem is there is shortage of doctors everywhere. The shortage of doctors everywhere, like in the emergency, especially when we had COVID. Anyway, fortunately for myself, I was already out of hospital. It was terrible. Yeah. It was quite challenging for doctors who were working in hospital to see all of these people dying in their hands. You need to protect yourself with all of these gears. So it was quite challenging. Yeah. So it can be hard working in the hospital, but thanks God, some people like it.
Yeah.
Yeah. Which is good, because when you get sick, this is where you're going to see the importance of those people. Yeah.
Coming to a family practice, what do you enjoy most about family medicine?
Okay, family medicine, interesting, discipline. Very interesting. You don't get bored of, So because it's family medicine, you're dealing with anything that happened in the family. Yeah. That is the advantage. You're not going to be bored, like say, same thing over and over. No. The first patient might be 87 years old. The second one is a 2 days old baby. The other one is a woman. The other one, is a man who comes with, people come with a different sort of thing. Yes. You don't get bored at all. So your mind keep working continuously. Yeah. I love it. Yeah. On the other side, it's not always, good. We have a lot of paperwork.
Yeah.
Oh, yeah. That you need to, it's something that really takes your time, and that time you don't have it. Sometimes, yes, you don't have it. Yeah. And the other thing is, like being in family medicine, we deal mostly with chronic conditions. High blood pressure, diabetes, asthma, COPD, you name them. Yeah. But one of the other things I've seen in Canada, people like medication. And people are almost conditioned that any disease, you need to get some medication. Yeah. And people come to do that all the time. And that can be challenging. Because I would like to see people improving, sometimes like being healed. But most of the time, family doctors, I think this is one of the things I put in that post you saw online. You end up being the managers of these chronic conditions.
Yeah, I think that's a great time to segue into that post. And for the audience who's watching, that link will be down in the description box, so you can go and check out that blog post. But what was your thinking as you were writing that blog post? What prompted you to finally put out there some of the concerns that you just shared now?
Yeah. Well, I kind of threw my heart into that. So these are the things that the trends I've been seeing. I remember when I just landed, when I started working up north, my very first patient was, I believe, 65 years old woman with a lot of chronic conditions. She came to refill medication. when I look at this is one of the challenges, by the way, when I went through as well. I look at the prescription she was having on her hands. She was having like 23 items. Medications. 1, 2, 3, 4, 5, 23.
Wow.
And out of those 23, are you only maybe 5?
Wow.
Yeah. Because the medications name change from one country to the other. That is one of the challenges as well. Yeah. You come up here and then you need to know the specialties or the brand names that are used in Canada. At that time, I didn't know. For example, I remember spending 30 minutes with that woman just to refill medication. So imagine you can't prescribe something that you don't know. For example, Tylenol, that we call Tylenol here.
Yes.
In South Africa, it's called Panadol. Yes. I didn't know that.
Yeah.
Yes. This is acetaminophen. I didn't know that. So one medication can have 3 names. I remember going on the internet, what is Tylenol? And it's, this is paracetamol. Come on. Yes. Yeah.
Yes.
And that took me time. So it is one of the challenges as well that I went through, apart from some of the, weather challenges and things like that, coming from one place to a cold environment. Yeah, these are small challenges, but some of them are medications. I realize that people like medications. Yes. And that sometimes it saddens me because I would like to see people improving and leaving the medications behind, improving. But the population has been conditioned to this extent that, imagine somebody coming, for example, you tell them that your blood sugar has gone up. There's something that you can do to just say, okay, though, so now, are you going to give me a prescription? No. The first prescription is not necessarily medication. Yeah. And sometimes that takes you time. And the other thing is what? How many times I've seen that I've really reported myself that I didn't want to give antibiotics for a mom who was coming with a child with common cold. So you end up spending so much time explaining. So I tend to see that among the immigrants.
I see.
Yes.
Yeah.
Among the immigrants, because we have, Canada is a place of migration. Yes. They say that like 50% of people that are living in the city were not born here. Yeah. So you have that, especially the population of immigrants who likes using antibiotics for nothing. And that takes time. You explain before you know your time is gone. I would have liked, that's why you've seen all of this building up progressively and until I put out that post you saw.
As I was reading that post, I think the thing that, well, one of the things that struck me the most was that you didn't start in medicine. You started in agriculture, I believe it was.
Yes. Yes.
So talk to me a little bit about that and how that shaped some of the beliefs that you have now around how we should be caring for ourselves.
Interesting. I think what God doesn't do things by mistake. Yeah. He knows why he brought me through agriculture. So that is my basic degree. I'm actually an agronomist before coming to medicine. I could have gone and worked in agriculture, but I chose to go to the university. And went to the university as well. I didn't start in human medicine straight away. I went to vet medicine. Spent like 2 years. I had to go in the third. Then I switched to human medicine. Yeah. And all of that has really shaped the way I see the world. So I end up liking the environment. I mean, the trees, the nature.
Yes.
I love it. Believe it or not, I've built like 4 2 or 4 greenhouses here in Canada.
Really?
Oh, yeah. Oh, yeah. I just like little plants.
Yeah.
Yes. They give it a try. It just, like when I'm gardening, it's imagine like when you come from my clinic, I go to my garden. I like it, so relaxing me. And imagine you're feeling so good working in your garden. Yes. And then you could tie that as well to producing your own food, where there's no pesticide, where there's no fungicide, where there's no preservative. Yes. So this is taking all of this. I've seen my patients struggling with medication. Because medicate people, what they don't understand. And sometimes we struggle with that, especially in seniors.
Yeah.
They've got so many medications.
Yeah.
Now you have to prescribe another medication to stop the side effect of the first medication. The second medication you give, it gives you again side effect. I will give you an example.
Okay.
The simple ibuprofen that we're taking.
Yes.
It can give you it can even make a hole into your stomach. Oh yeah. You give it to the patient goes there, the new cans will be okay.
Okay.
The next day they phone you, doc, I feel this terrible pain in the stomach. You've created the second problem. Now to stop that, to do what? We can give something to an antacid. You give that, patient feel better. You give it for maybe like 1 week or 2. Because they feel good, they don't want to stop it. The second medication can cause, if you give medication to stop the acid, it can cause a problem of iron absorption.
Oh my goodness.
So that patient might end up with iron deficiency, anemia.
Well,
can you see we go like that from one thing to the other?
Yeah.
Yes.
Yeah.
That's why I'm saying why can't we in our patients that what we're prescribing is good, but sometimes it's just too much. Patients, they like it, and ourselves will end up prescribing. Go. So this is a certain time where you don't have that really happiness of just prescribing medications. I would like to talk to the patients. But that brings us as well to the second challenge.
Yes.
The time.
Because of time.
Yeah.
Before we get to the time and how you're trying to solve that issue of time, I want to get into, the idea that you presented in that blog post, which I think is a real paradigm shift.
Yes.
So I don't want to say too much about it, but can you explain to us how you got there and what it is?
Well, the principle, if I can call it that way, is called homesteadication. It's just a combination of 2 words. Homesteading. Homestead, it is a word that exists in English. Homestead came from, it is a principle of people who tend to live fully and independently in the land. Yeah. So they tend to cultivate their own food. They preserve their own food. They cook at home. They don't use chemicals. They exercise, because working in your own garden is type of exercise. Being in the nature, it is an exercise. So you're connecting with the nature. For example, when you work in your garden, there are some bugs that you get by breathing the air that will really increase the quality of bugs you have in your gut.
Interesting.
Oh yeah, it makes you feel good. For example, I will give you an example. They say life starts in the gut. Yes, life starts in the gut, and many diseases start in the gut. For example, we have a problem of anxiety and depression. Do you know that serotonin, the a hormone that makes us feel good. 90% of it comes from the gut. Yes. And many people don't know that. So when you go to see a psychiatrist, they put you on medication for anxiety.
Mm-hmm.
That medication targets only like roughly 10% of serotonin that goes to the brain.
Mm-hmm.
And we tend to forget the 90% that comes from the gut.
Mm.
Yes. And for you to have that good type of bacteria, you need to eat healthy. Where you don't have preservative, you eat good fibers, less salt, less sugar, you exercise, you have good rest, and then that gives you, you have good bacteria. When you have them, you live well. So that is number one thing for advantage of people who are living or doing the homesteading. Now, the second word is the cation that you see at the end there is just the last part of medication.
Yes.
So medication, we know it. It helps us, even though sometimes we tend to abuse it. Doctors and patients alike, you put together homesteadication.
Yeah.
Yeah. Which is just a way of living, like using the principles of homesteading as medication.
But I think in North America, that's a big shift. That's a big shift.
Yeah.
But it's one that you are championing. Why?
Well, we would like to bring many people to live this way because there's a lot of benefit. Medications don't solve all the problems. They don't solve all the problems. And the second big problem we're having as well is our food industry. Yes, I talk about that in my post. The food industry. The food we're having today is not food we had 30, 40 years ago. No, some are not even food. They are man-made. Yes. Because if you put the right food in your stomach, the body knows what to do. It will absorb the nutrient. Whatever is left goes out. But if you put something that is not food, the body doesn't know what to do with. God forbid, if that's whatever you put in your stomach manage to get into your bloodstream, it can really trigger a cascade of reactions that no one can believe. It can be the cause, that is the biggest cause of all the diseases that we cause today, autoimmune problems. So the body was like, what's going on? There's something going into my blood. So your immunity is just in alert. It starts firing everywhere. So if you have that war between that whatever you put into your stomach that now ended up in your blood, it causes what we call autoimmune diseases. Yes. So if it is in your thyroid, the thyroid is gone. If it comes in your skin, we talk about psoriasis. If it's in your joint, rheumatoid arthritis, it can attack any part of your body. Yes. It's so common. So it starts with small things, food. And the other part is what they are GMO, genetically modified food.
Yeah.
Which are not real food.
Yeah.
They can cause the same problems.
So let's talk about food and the food that we're consuming today. What's making our food so problematic?
Well, big problem actually. Big problem. Yeah. The Bible talks about the food as first medicine that we need to take. And unfortunately, the food we're eating today, as I said, is not food. Many of them are man-made or modified, like GMOs.
Yeah.
And then on top of that, they put preservative. Yes. It's almost this environment. You see, when we have like a corpse, so the corpse doesn't rot, and the environment. So it's almost the same thing. They put so all sort of chemicals. Yeah. Even before going to that, like in husbandries, they put hormones, antibiotics, so that the animal can grow fast. Yeah. You look at the chicken we eat today, they are really chicks. Very 2, 3, 4 weeks, 1 kilo. They grow so fast because they pump all of those chemicals. And then when you eat that, it goes into us.
Yeah.
The same, the preservative they put in the food, so the food don't get wrong. Yeah. This is what actually start triggering my reaction or my observation.
Yeah.
I remember 20 years ago, my wife brought some grapes from the local store. It looked so gorgeous, so nice.
Yes.
And I went there, wanted to grab one just to eat.
Yeah.
And here they were like red marks on it. You need to make sure that you wash them thoroughly before eating. That's caught my eyes. I wanted to know more. So as I was reading, in the fine print, I could see it was treated with a chemical whose name I could not even pronounce.
Yes, yes.
And I had to search it up.
Yeah.
With myself, I went word by word. And then it brought a name. I went online.
Yeah.
It brought me an article. And that chemical was banned in the U.S.
Yes.
And yet those grapes were coming from California.
Yeah.
So really in BC, California to here, I mean, it takes some days for it to end up on our shelves. But they look like coming from the local farm.
Yeah.
So they don't rot. You can leave it on the table 2 weeks, 3 weeks, 4. They seem the same.
Right.
So that was a fungicide,
Yeah.
a chemical that they spray so the grapes don't rot.
Yeah.
Yeah. And that chemical is the cause of one of the problems. It destroys basically our thyroid,
Yes.
causing what we call hypothyroidism.
But how many people are going to Google that? Like you, yeah.
Yeah.
You trust it at the grocery store, yeah.
And when you look at the number of people on hypothyroidism medication,
Yeah.
you just see that big correlation with what we eat and the disease we are having. And yet, thyroid is very, very important for our metabolism, for our functioning, our digestion. It's very important. Our sex drive, it's very, very important.
Yeah.
You don't have it, even our brain, memory.
Yeah.
So this is how we came up to why this is banned in the U.S. because it's for exportation. They send it to Canada. So what I'm doing it actually interpeling is really talking to everybody. We have to act into this. Yes. So the other problem that I've noticed in family medicine setting,
Yes.
I will ask you a question. Have you ever heard or felt like when you go to see a family doctor, you feel rushed?
All the time. All the time. Yeah.
Why do you think it is for?
So, I mean, we know that there's not enough doctors. We know they don't have enough time.
Mm-hmm.
But yeah, you go in and you got to be in and out maybe in 10 minutes. If it's a 15-minute visit, for me, it's a long visit.
That is actually too long. If one is giving you 15 minutes, yeah. Okay, so to put in perspective, most doctors here, we are paid by fee for service. So it means you do the fee. I mean, you treat the patient, they pay you.
Yeah.
So you have to make the volume.
Yes. Yeah.
For you to sustain all the overhead, we live in Vancouver, see, one of the most expensive city in the world. So for you to pay your rent, to pay your staff, to pay your consumable, all of that takes money.
Yes. Yes.
So for you to make that money, you need to see volume.
Yes.
That's why people tend to go fast to make that volume.
Yeah.
And as a consequence, the quality of care sometimes is compromised.
Mm-hmm.
Yes.
Mm-hmm.
Because we end up not really digging into the root cause of diseases.
Yeah.
That's why sometimes doctors will just, you speak, they give you medication. Yes. So compared to, the fee for service can be compared to system of capitation, for example. This is one of the systems where they give you a number of patients.
Yeah.
You need to maintain their health, keep them healthy.
Yes.
Do whatever you can do. Go to job with them. Organize group meetings. Keep them healthy. Solve the problems. The happier they are, the less they come to see you.
Mm-hmm.
So then you have time for yourself.
Yeah.
You insist more on prevention.
Mm-hmm.
Teach them how to eat well.
Mm-hmm.
You teach them how to move.
Mm-hmm.
You teach them how to sleep, because the sleep is very important.
Mm-hmm.
You teach them how to avoid preservative, how to avoid sugar.
Mm-hmm.
Then they stay healthy.
Mm-hmm.
How often do you go see a doctor if you're not healthy, if you're not sick?
You don't need to.
Yeah, you don't need to. Is that? Yeah. People come to see us when something is wrong.
Mm-hmm.
Yeah.
Mm-hmm.
So if they are healthy, they don't call you.
Yeah.
So
It should
then
be a good thing.
Yeah, exactly.
Yes.
Yeah. Should be a good thing. Yeah. And that system is called capitation.
That's free.
Yeah. So I like it because you can end up spending time. If the person comes with 2 problems, you ask more. You want to solve all the problems so they can go and get healthy.
Mm-hmm.
You teach them how to eat well, how to take care of the disease.
Where do we see that system working? In other countries?
Well, we do have here, I believe Ontario has such a system.
Such a system. Okay.
Yes. And sometimes it can be blended, but you end up insisting mostly on prevention, which is good. Personally, I like it.
Yeah.
Yeah.
Yeah. So what is your solution, I guess, to that problem? How are you going to bring homesteadication in a way that's accessible?
Okay.
Through this channel, through your blog, how are you going to be bringing people into this paradigm shift and getting them the knowledge and the information they need to live healthier lives?
Good. That's a very good question. To start with, I like teaching. Yes. One of my background as well, that was even before I finished my medical school.
Yes.
I thought I was teaching English.
Oh, okay.
Yes. So from there, I was like tutor of English when I was medical school.
Yeah.
Yes. So after that, because I went to, Congo is French-speaking country, but I went and did English. I loved it so much that it was a time when the university was temporarily closed for 1.5 years or 2.
Yeah.
Yes. So I ended up teaching in that school. I love teaching. So once the university reopened, I went back to finish my medical school.
Yeah.
And ended up in South Africa. From there, came up here. And even here, I am a clinical instructor with the University of British Columbia.
Yes.
They do send us some students here.
Yes.
I love teaching.
Yes.
I like talking to my patients, talking to my students, teaching them, telling them this. When they ask questions, you even learn more. I like that. Yes. That's what I would like to utilize that. It's one of my passions. I actually end up seeing most patients because I want to explain things. Yes. 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 And sometimes, diseases in patients, they tend to be the same. Yes. You see like 3, 4, 5, 6 patients, one after the other, having the same problem. Diabetes. You explain.
Yeah.
And then the idea came, I was like, now we don't have much time to explain all of those things.
Yeah.
And sometimes patients themselves, they'll shut you off politely.
Yeah.
When you start taking a bit more time, and then they'll talk, I'm at work, my lunch is finishing in 1 minute. Yeah. Can you just give that medication? Let me go. And then you end up doing that. So now, I was like, they still need to hear this.
Yeah. It'll help us.
Yes.
Yeah.
Is there a way we can work through that? We can create maybe some videos teaching them how they can manage their own problem. So this is how we came up with this. And I think the time that was just preparing for the time to come so we can start this, give more information to the patients. It's a way to empower them. Imagine we have this information somewhere, like in any social media, where people can go there and listen as many times as they want. If they have problems, then they can come and we discuss.
What kind of topics are you hoping to cover?
Well, as I told you, family medicine is so broad. Yes. Yes. It's so broad. So my focus first, it will be on the immigrant people.
Yeah.
Yeah. They have many of them here. They have a lot of people from South Asian.
Yes.
A lot of South Asians, a lot of Africans,
Mm-hmm.
a lot of Europeans, some of them who can't even speak English.
Mm.
And even though we don't take new patients, those patients we tend to take them just,
To help them out. Yes. To help them out.
Yeah.
And this resource as well will help them out.
Exactly.
Yeah.
As a matter of fact, we're actually thinking that this can be converted into French
Yes.
for French-speaking people so they can, enjoy this as well. Yeah.
Ultimately, it seems like you want your patients to see less, but ultimately it seems like you want your patients to just live a healthier life.
Exactly.
Yeah.
Exactly. But the system in which we are, your patient seeing you less means you won't be able to afford this.
You'll get new patients.
True.
Yeah. But ultimately, the goal is a healthier life.
Yes. If we can give them the tools that you should take a disease for like diabetes.
Yes. Yeah.
I usually tell my patients that diabetes is like a car in which you are the driver. You are seated behind the wheel. On your right side is your family doctor. At the left side, you have your endocrinologist, especially who treats diabetes. At the other side, you have the dietitian. And at the back seat, you have your coach who can teach you how to move. All of these people come to help you. So it's you who knows where you want to bring your car. Yeah. So we will not force you to do those things. We give you the tools, how to eat, how to move, how to rest, when and how, so you can manage your condition.
Yeah.
Otherwise, you end up with complications, kidney failure, infection that never end, and the lifespan is shortened.
But a better lifestyle, obviously.
Oh, yeah.
A longer lifespan.
Yeah. So that's why this is what you want to bring in homesteadication, the lifestyle of people that are practicing homesteading, using that as medication, so that we don't only rely on medications. Yeah. So many of our topics will be based on that, on how we can empower people manage their chronic conditions. Yes, like diabetes, high blood pressure. And many of these conditions can be reversible. Unfortunately, our patients, they're so conditioned to taking medications that sometimes they come to see you, they say, oh no, your blood sugar is going up. So are you going to give me a prescription? Sure, but you don't need a prescription. You just need to change a bit the way you eat it. And then the sugar will stabilize itself. Yeah. So for people to adhere to this, they need to understand the principle itself. So there's no time to spend that time with them in the practice. Yes. That's why we'll be giving them resources to which they can be going, listening over and over at their own pace so they can know how to solve their own problems.
I think we'll leave it there for this first episode. Just the idea of being able to solve their problems, I think, is is exciting. And the idea that there will be a place where patients locally could get that information, that resource, that support, I think is very exciting.
Okay.
So Dr. Kabongo, thank you so much for what you're doing. And we want to encourage the audience, keep an eye on this space, keep an eye on this channel, because more of that information is going to be coming your way in the weeks and months ahead to help you live a healthier life. Thank you so much, Doctor.